Well, my apologies for some technical difficulties, but for everyone watching right now, yes, good evening to everyone tuning in for this event. We are sorry for a 4 minute delay, but we are more than sure that everything will go according to plan for the rest of the webinar. I am more than honored to host this year's last webinar, which is Therapy Interfering Processes. In my opinion, this concludes a very successful and educational webinar series started and produced by European DBT Association. Just a reminder that you can still find all of the previous webinars on our webpage, edbt.eu, or here on our YouTube channel, and you can subscribe here as well. My name is Romija Krezinja, and I'm a member of the EDBTA Dissemination Committee, psychologist and DBT practitioner, a lecturer, and a student as well, all at once. I'll be your host and moderator for tonight, and with me today is Zachary Rosenthal, Associate Professor of Psychiatry and Behavioral Sciences and Associate Professor of Psychology and Neuroscience at Duke University. Widely recognized for his work on misophonia, emotion regulation, borderline personality disorder, and technology-enhanced behavioral interventions. A man who has published extensively on cognitive behavioral and dialectical behavior therapies, including his latest book, Managing Therapy Interfering Behaviors, Strategies from Dialectical Behavioral Therapy. Hello, Zach.
Hello, Ramia. Thank you for having me.
Yes, thank you for joining us. So, in my opinion, therapy interfering processes have been a headache for therapists already beginning of therapy itself. And I think it plays a very important part, not only in DBT, but also in every therapy modality as well. I feel that DBT has conceptualized therapy interfering quite nicely. At the same time, I've been to a lot of therapist team meetings where this has been, a little bit brushed off or not, addressed head on. So I'm just curious, like, what exactly interested you in this particular subject, or are there any like stories behind it?
Well, thank you again for having me. It's an interesting question to frame this topic. First, you'll see as we go through this today that I fully agree with you that this is a really core underlying problem, not just in DBT, but really across psychotherapies. And I'll talk about how that's probably true across therapies and really isn't unique to DBT. And yet there are some things we do with DBT that are arguably unique. For me personally, to directly answer your question, I think the short answer is I experienced in my early years of graduate training a lot of really difficult experiences learning how to work with patients with borderline personality disorder. And they were difficult lessons and valuable lessons. And one of the things that emerged from that as I kind of got going further in my career was just a real recognition that understanding therapy interfering problems is essential to being able to stay fresh and healthy and motivated as a therapist. And so this is something I've been interested in my whole career. The latest book you cited is actually a book from 10 years ago that Alex Chapman and I wrote. And it's something that I've continued to give lots of trainings and talks about since and just really quite interested in. So it's an honor to be here, and I'm looking forward to talking more about this.
Yeah, well, thank you for your answer. And I think it just reminds me on how on an airplane you have to put your own mask first before you help others. So I find it at its core. So I will not disturb you anymore. I'm all the stage to you. I'm disappearing, and yeah, good luck.
Okay, well, thank you again. And I think you'll share questions roughly in 50 minutes or so, and we'll go through
Good.
some Q&A then, correct?
That's correct.
Beautiful, beautiful. Okay, everybody. So I'm going to just jump us in. We are getting started a couple minutes late, so I'm going to move us through some things and hopefully keep you fresh. I know it's for you all in Europe. It's a Sunday evening, so thank you for being here with me and with everyone. I want to just thank the folks who set this up, Romia and her team, and Martin for inviting me to come here, as well as really everybody who's helped me in my career get to this place, from early mentors to my own trainees and students over the last 25 years at Duke, and to my current Duke DB team. So thanks everybody for making this happen. Before I launch in, I think it's appropriate to indicate possible disclosures. So I'm uh, just going to leave this here up on the screen for you to read. Um, I uh, I think it's fair to say I really am balanced and critical and open-minded about DBT, but I do have biases and blind spots. I do have a book, and I do get paid for things related to DBT. I also just really value DBT and find myself probably at times, based on all of the things I've done with DBT in my career, just probably favoring it over some other things. So you can keep that in mind as you listen to today's talk and think about any biases. Okay, so our primary goal for today, for this next hour or so, is to increase your clarity, confidence, and skill addressing therapy interfering processes in DBT, but also in other treatment approaches beyond DBT. And one thing you can see right away on this screen is that I'm not using the word TIB, or therapy interfering behavior. I'm going to use TIP, therapy interfering processes. Today, I'm going to introduce that to you. It's actually the first talk I've given outwardly publicly where I've introduced this transition from TIBs to TIPs. And I'll walk you through why I think that may be valuable. So in DBT, we all know you all are presumably all well-trained DBT clinicians. Some of you probably have lots and lots of experience. So you already know what's on this screen. TIBs from a standard DBT framework. This is a term we use that refers to a broad category of actions, behaviors, that the client or patient, or you, the therapist, does that in some way, shape, or form adversely impacts either the process or the outcome of the work you're doing. So TIBs, think of it as sort of a mega class of behavior, a really broad class of behavior. It's not at all specific, but it's a really useful on the treatment hierarchy in DBT. It really, as we all know, is quite valuable in that space between life-threatening and quality of life interfering behaviors as a target class of behaviors that we intervene upon in order to be able to help our clients and patients live a life worth living that is valued. So TIBs and DBT, what are these usually? Well, again, you all know this, but just to kind of zoom us in really granularly, and for those of you who may be listening who are not as familiar with TIBs in DBT, here are just some examples. On the left, we have our patient-client common examples. The right, we have our common therapist examples. By the way, none of this is intended to be comprehensive here. It's really just a way to give you some very typical common kinds of problems we see. Okay, so I won't read through them all, but you can see the kinds of things we have, right? These are typical. If you're a DBT therapist, you know and you've experienced probably every single thing on the left, and probably you or people on your team have experienced everything on the right. So these are common, but notice what you see in all of these things. These are behaviors. These are behaviors, or they're the absence of doing some sort of behavior. And we could also list many, 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 many more if we so wanted to do. So TIBs are common in DBT, and there are many. Why should we change our terminology from TIBs to TIPs? I'm just going to quickly make this argument and then move us into a set of strategies we can use in DBT to address TIPs, but also strategies we might use outside of DBT that are very informed by DBT itself. So first, TIPs really reflects a more modern and mechanistic focused update. What do I mean by that? Well, I mean processes, underlying processes that are biopsychosocial, those are relevant across many different, more modern interventions, be they within the family of cognitive behavioral interventions, or be they outside of them, we've seen the science progress quite a lot since DBT's first innovation in the early 90s. One of the things I remember Marcia saying many times when I had the great privilege to be around her in regular meetings, she would say, and I heard her say this publicly as well, DBT must move and advance and evolve with the science over time. It is not set in stone, locked in 1991 in the Red Book. And it's not locked in stone by way of the skills that we've seen get iterated over the years, but also outside of the skills themselves. If we think about the treatment and the way we use the treatment, over time, science has advanced, and one of the major advancements in our field has been a real shift to more mechanism-focused, process-focused, and dimensionally organized understanding of psychopathology. So TIPs moves us a little bit away from kind of a concrete behavior and into a more mechanistic focus. I think also, on every team I've ever been on, I've been doing DBT since 1996. And every team I've ever been on, the way therapists talk about TIBs, it tends to it tends to be really primarily about observable actions only. And the last slide we just looked at, these are all observable actions here. They're observable behaviors. But actions or behaviors we can observe only tell us what happened. They don't really inform us why, and they don't really point to underlying mechanistic processes unless we go there and we assess and we discern them, which is, of course, something we do well as DBT therapists. Similarly, our therapy interfering factors, they're not just topographical behaviors, they're actually underlying processes. So the behavior we label as a TIB, we end up as DBT therapists conceptualizing this, and we end up contextualizing it in order to address this. So using the term TIP, I think kind of brings us right to the need to conceptualize and contextualize. And I've just put an example here, right, that like skills practice non-compliance in our patients. We have to understand that in context. We have to conceptualize that. And it might mean many, many, many different things for the same patient, or of course, across patients. The underlying processes behind non-compliant skills use are going to be variable, aren't they? So just focusing only on the patient didn't do the homework, this just gets us at sort of the tip of the iceberg of the topography of the behavior. It's not actually that interesting if we think about it. What's really much more useful and interesting is what is going on why in context, right? So our chain analyses discern the function of the TIB, and we link back to the case conceptualization and to context. And noncompliance could be understood, for example, as apparent competence or active passivity. It can be understood as all sorts of different underlying classes of behavior. We have to figure that out in our chains, don't we? Right? So as we do that, we're already going to be jumping right into processes. Why aren't we just starting with TIPs as processes, right? Processes provide a better frame because they get us right to biopsychosocial mechanisms about patterns of behavior in context. And processes here are not made up by us. Processes have known scientific or theoretical basis. So examples of processes, I'll talk about this a lot here, but examples, escape behavior, avoidance behavior, right? Those are processes. Hypervigilance, alexithymia, somatic hyperarousal. Maybe the patient exhibits a lot of indirect aggression. Maybe there's internalizing or externalizing cognitions, right? All of these are kind of at this level that they're deeper and richer than just the behavior's surface, and they allow us to move to case conceptualization to figure out what might we do to intervene and how. So moving from TIBs to TIPs, it gives us a more mechanistic, process-based, and explanatory focus. I also think it's more compassionate, it's less aversive, and can be perceived by patients and team members as less blaming. When we talk with our patients about therapy interfering processes, we normalize them. When we talk on team about processes, we're understanding why they might be there. So we're less likely to do something that is experienced as aversive, right? It's not, oh, well, today we have to do a chain because you didn't do your homework. Aversive, 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 right? And how many patients have you known who don't take to DBT in part because of this? Instead, let's together understand what got in the way, and let's really do this in a way that highlights and gets us closer to understanding the processes at play here. Let's figure this out together. A process-based focus enables us earlier intervention before the behaviors emerge because we can talk about all this as a part of the assessment and case conceptualization before we even get to the concrete TIB. And again, it allows therapists to turn the patient verbal content into meaningful therapeutic processes that are tied directly to the case conceptualization, tied directly to the clinically relevant problems. So here, what do I mean? I mean, this frame allows us to rapidly convert any patient content into process. Convert convert content into process. This TIP focus accelerates our ability to do this. And for patients, again, it might reduce defensiveness and shame, moves us from you did something bad or wrong to there's something important for us to understand. TIPs might help us improve insight and agency, right? So understanding why somebody does the things they do allows us to more immediately, rapidly get into understanding this stuff. And again, more validating perhaps, and consistent with the biosocial model. So this approach, I'm arguing, if we just make this one letter shift, is very easy for us as therapists to do. We just have to change the B and swap it out for a P, and it actually just opens up some doors. It doesn't dramatically change everything. I'm not here to overhype that, but it does do some things for us that are actually easy to do. And for us as therapists, it allows us to right away get at mechanisms, get less stuck on behavior. And if you're an advanced DBT therapist, this might just be second nature to you. But here's the thing. The vast majority of DBT therapists are not advanced therapists yet. They're learning, they're new, right? And so new therapists need from the get-go to be able to identify mechanisms, not just behavior. So the other thing I think is really fun when we do this work, now we start looking at therapist processes dyadically with the patient. So our therapist TIBs become therapist-patient dyadic TIPs, perhaps. We can understand therapist avoidance, therapist threat sensitivity, therapist invalidation in a dyadic context, right? So we aren't just being invalidating, we're invalidating accidentally in a context that's useful to understand based on a case conceptualization. So all of this, I think, can help reduce therapist burnout and therapist sense of self-blame. It also helps us let go of this word that I'll just be honest with you, it's a word I don't use, and I actively train my DBT learners not to use this word willfulness. This is, in my opinion, at least here in the States, a pretty unhelpful word to use. It's not exactly a specific construct. If we think about TIPs, their learned patterns and context, it's not just our patient being willful. Willful is no different than saying our patient is being resistant, right? Instead, let's think about what is the function, what is the context, and so on. And last here, and then I'll move us on and get into the meat of this, using a more process-focused approach, it aligns us as DBT providers. It updates DBT, again, with a more modern clinical science. DBT is a process-based therapy, right? If we think about where the field has shifted in the last 5, 6, 7, 8 years, we are now talking about process-based therapy as a scaffold, a sort of meta framework for how anyone can do any psychotherapy. And some evidence-based therapies like DBT are process-based. They have certain processes they target. So DBT as a process-based targeting things like problems with emotion regulation, if we use a process-based way of understanding TIBs, it already kind of rotates us over and kind of just helps us get more aligned. Similarly, with high top or the DSM-5 alternative model for personality disorders or the ICD-11 dimensional classification of personality disorders, all of this is everything there is a shift in the last 10, 15 years to a more dimensional process-based way of understanding things. And it's time, I think, for DBT to move along with this shift. We don't want to be left behind. Okay, so here's a dialectic. Here's a dialectic. If we now embrace this sense of therapy interfering processes or TIPs, we're DBT therapists, right? So we have to think about what's a dialectic here. And a really simple dialectic here, using this acronym BASIC, which I love and have written about because it allows us to look at biopsychosocial processes at the idiographic patient level. If we use BASIC, we can now say on the one hand, there may be deficits or too little of a certain biopsychosocial process, and that too little of that, not enough of that, is problematic and showing up in therapy that's getting in the way. Or we can do the opposite dialectically. We can look for excesses, too much of something. Now, I like this a lot because it's really simple. It's really simple. It's just like a rough way to cleave a lot of complicated stuff in half into either too little or too much. And then we can look across these different domains of functioning. These domains of functioning are human domains of functioning. They're not unique to any therapy or any person. This is just a way to understand human beings transdiagnostically and from a more biopsychosocial and process-based approach. And I've just put examples. These are examples. This is not comprehensive. It's just a way for you as a therapist to think, how might I, in a case formulation, understand what kinds of TIPs I might expect? There's behavioral, attentional, somatic, interpersonal, and cognitive types. And of course, beyond BPD, we see TIPs related to any problem. If we move outside of DBT for a minute, we move outside of thinking about our BPD patients. Once you know on the left side of the screen here are diagnoses, once you know what a diagnosis is, you already can have hypotheses about likely TIPs, candidate hypotheses, right? And same thing on the right side of the screen, forgetting about diagnosis, if what you know is there's a presenting problem, you can expect that these things will show up in some way, shape, or form, right? And they're going to show up as TIPs with you, not because your patients are bad or broken, not because you're a bad therapist, but because human beings engage in patterns biopsychosocially over time and across context. And so we can expect that we'll just, we as therapists will get in our own way and our patients will unintentionally get in their own way as well. And the way we get in our way and the way they get in their way is based on the very thing that we are presenting to treatment with. So let's talk about DBT. Let's zip right into this. Here's actually, if you were to take one screenshot of today's talk, if you've already tuned me out completely, like Charlie Brown's teacher back in the Charlie Brown series, the wah 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 wah. It's fine if you've done that, but tune in to this moment and take a screenshot of this screen. I'll even wave at you because this is the screen that tells us what we can do. And this does come in large part from the book that Alex Chapman and I wrote 10 years ago. It's just been expanded and updated by me here in the last 10 years. So I'm going to walk you through now. The rest of the next half an hour is going to be walking through each of these different 10 strategies for how DBT therapists can manage therapy interfering processes. And at the very end, we'll talk about how we can adapt these 10 strategies for any therapy outside of DBT. Okay, so first things first, and I would say, and I do say, I have said for many, many years, this is the most important step right here. I do this early and direct orienting to TIPs in the very first evaluation appointment. I train my learners at Duke every year. The first appointment before we finish, we're going to orient and we're going to get permission to notice therapy interfering processes and link them to clinically relevant problems outside the psychotherapy. We're going to link whatever they do with us that gets in the way to the very things in their life that are getting in the way. We're going to anticipate this very non-judgmentally. We're going to normalize this, and I'll show you what I might do. So I might say, for example, can I share something with you before we finish today? Can I just mention something about what we might expect could happen in our therapy together? I usually, say some other things in here like, I've been doing this a long time and here's some things I've learned and da 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 da, right? Just being really radically genuine. So, one of the things about therapy that's really, really frequent and I think happens because all of us, including myself, are kind of imperfect. We're just people, right? We're fallible. We're not perfect, and we have patterns that we've learned. And sometimes, unfortunately, the patterns we've learned, they kind of end up working, I guess, against our own interests. So I'll say something like, so here's the thing. The very thing that brings people into therapy can unintentionally get in the way of therapy working or helping. And the patient looks at me usually and is like, huh? What? And they think about it for a minute, and then many of them go, oh, yeah, that makes sense. What do I do next? I first, always first after this, use a non-threatening example, maybe two examples of TIPs completely unrelated to the patient. I say something like, we've just met, but from what I know, I don't think you have problems with ADHD, or you could insert anything you want here that's you're very certain the patient does not struggle with. So I might say, I don't think you have problems with ADHD, but my patients who do have problems with ADHD, when they come into therapy, they have difficulty focusing or they get easily distracted during treatment. Or they might like have a hard time figuring out like planning and organizing their day. They might miss therapy appointments because of that or whatever. For patients that are like not like you who have major life problems, they want to change because of hostility. And I know you don't seem like this is a problem you're here to help me to get me to help you with. But I do get patients who come in here who have problems with hostility. And if that were the problem, I would expect with them that in some way their problems with hostility, it will likely get in the way of me helping them change their problems with hostility. And here's where, after one or two unrelated to the patient examples that are non-threatening, the patient gets it. They get it every time. And because it's been non-threatening, their defenses are down, their arousal is down, they're kind of curious. They're trying to understand what in the world I'm talking about. So then I say, what do you think? For you, you know you better than I know you. We've just met. What do you think might be one or two patterns in your life that you're here to change and you want me to help you change, but might actually get in the way unintentionally get in the way of the therapy working? What do you think? Like, what can we predict together? What can we predict together? We together, right? We together, very collaborative. We're on the same team. This is just going to be a thing we're going to sort through together. Now, I then say, okay, thank you for sharing that. And if that happens or anything like it, is it okay with you? Can I have your permission to gently notice it and see if it's something we might want to pay attention to and work on together? And I'll tell you guys, I've been doing this now for a long, long time. Knock on wood, I have never once had a patient say no to that question. Never. And I've never seen any of my learners, my trainees at Duke, have a patient say no. Why? Because all I'm asking with that question is, may I have permission to help you? May I have permission to understand you deeper? And this is what our patients are here for. So if you kind of move through those steps just like I outlined, I am here to say I am highly confident you will find your patient is willing, even patients who are maybe more difficult to treat up front, they will be willing to say, okay, yes, help me. Now, that's the hardest part. And if you haven't done that and you've gotten started with DBT and you're farther along, you can always go back to that. This is the point in the training where most people say, but wait. What if I didn't do that at the beginning of therapy? Can I go back ever? And of course, the answer is yes, go back. We're DBT therapists. We're fallible. We own it. We have flexibility, right? We can simply say, you know what? I realize I didn't tell you. I realize I was talking to a team the other day and I realized I didn't actually orient you very well or get your permission to talk about therapy interfering processes. Can I do that today? You can do that at any point in treatment, right? Own it, be genuine about it, move back and go back to here, right? You're getting permission. Now, once you've got that permission, now moving forward, now we're just going to number two, the next step is we're going to highlight. Highlight. We're just noticing. In DBT specific language, we might say we're observing and describing. And we're going to notice in real time. We're going to notice this might be happening. We're going to be behaviorally specific. We're going to be non-judgmental. We're going to try to bring their attention to what's happening in real time as a possible TIP. Now, critical to us as DBT therapists, we have hypotheses here, right? We have ideas about what might be going on. We don't make interpretations. We don't know what's going on, but we have ideas. We don't say them here. This is about like slowly, gently moving into this so that the process of working with TIPs is not aversive to your patient. So we're going to have ideas, but we're going to put them aside, right? Our hypotheses, they're over here. We're going to try to notice our assumptions or our biases. We're going to kind of put them over here. If we do have automatic thoughts that function as interpretations, what's going on, we're going to try to notice them and kind of put them over here. All we're doing is gently highlighting. That's it first. I like to gently highlight 3 times for the same problem behavior before I get in and start working on it. Because here's the thing, if it's only happened once, it's just a one-time only thing. If it's happened twice, you got a line, you got 2 things, but it's not a pattern yet. 3 times, 3 data points, 3 becomes that magic number, and now we have a trend. So for the first time or two, really gentle, you're just noticing and then you're moving on. You're not digging in deep and making a huge deal out of it because you don't actually know yet if it is, in fact, something that's going to be recurring. I've noticed you've not been coming to our sessions consistently the past week. Just highlighting. Just notice that. I'm just noticing that. Or if a client's not speaking, I'm not sure if you've noticed this, but often when I ask you questions, you'll say things like, I don't know, or you'll kind of provide brief answers and there's not a lot of detail. Is that a thing maybe we might want to talk about at some point? So we've got orientation and permission. Then we now move into highlighting. As we now get into working with the TIP, or perhaps when we are highlighting the TIP, we're going to then always begin as a next step with validation of the valid. You need to validate the valid part of what's happening with the TIPs, seeking that kernel of truth, the legitimacy, the effectiveness of what is happening, even if it is, of course, by definition, therapy interfering. We still want to lean in first with validation. We're DBT therapists, so we know acknowledging is not the same as agreeing. It's not the same as approving, right? But it is acknowledging something as it is. It will help our client feel understood and supported, even if we know that TIP will need to be changed. And of course, as always, only validate the valid, right? Be very discriminating in the part of the TIP that you validate. It should be something that's genuinely skillful, legitimate, true, effective, right? Make sure that's the part you're validating. Right? It might make sense the patient is being hostile with you. Don't conflate that with it's good to be hostile with me, right? It just might make sense and have some way to validate it. The last point here is that it's useful always to validate first before you go to the next steps to change TIPs. But the reality is sometimes validation cannot or does not happen first. And if you can be intentional when you don't validate first and have a reason why you're not doing that, you're probably going to be in good shape. The story I always like to tell with this is I had a patient many years ago, many years ago now, and she was someone who had a history of exotic dancing. And, uh, and she was very free with her body in the therapy sessions. And just this was her history. She was, one of those people. She's very free with her body. And there was a session where, and she had BPD and substance use and all sorts of problems. We were doing DBT, and at one point, and she had been very distracting, kind of saying things that were off topic and this and that, and pulling me away from getting the work done. And it was a very regular thing. She was fun to work with, and this is like a wonderful person, great human being, but like, just kind of all over the place a little bit behaviorally. And there was a session where we were talking about why she hadn't been to therapy in the last few weeks. And she'd been on a drug binge, she'd been missing for a few weeks. And I was trying to work through a chain to understand that. And she stands up and she says, "Oh, I didn't tell you, Zach, I got a new tattoo. You want to see it?" And I said, uh, and before I could even say no, she said, "It's right here." And this actually happened. She began, put her hands on her sweatpants, and it was below, it was down there, right? It was below her waist. And she said, "Do you want to see it? It's so beautiful. It's so cool." And I just looked at her and I said, "No, do not show me your tattoo. I do not want to see your tattoo." And I don't think I've ever been so forceful with someone in my whole career. There's zero chance I wanted that patient to show me her tattoo. So sometimes we don't validate first. We just block. We block the behavior, right? It's a true story. And she, of course, just went with it. "Oh, no problem." Sat back down and kept talking. It wasn't a thing. Validate the valid unless you should not, and you just need to block the behavior. Okay, next with our TIPs, we want to have contingency clarification and contingency management. So what do I mean? I mean openly talking about what will happen when these TIPs are relevant. This is similar to what we do with TIBs regularly in DBT. We openly talk about it. The difference here is that we're not just talking about a behavior. We're talking about the underlying deeper level processes that are patterns that give rise to all sorts of different topographical behaviors in that same category, that same functional class. Right? So when you are avoiding, when you are escaping, when you are doing things without thinking, right? Impulsivity. Right? Here's what I might do, or here's how that might impact our work. When you tend to do these kinds of things, guys, kinds of things. It's not just like when you don't do your diary card. It's whatever you've discerned the functions to be of not doing the diary card at a TIP process level. It's when that process is occurring, here's what we're going to do. Like, here's how I do this work. Here's how we do this together. Again, always linked back to their life as motivation to change, where outside of the therapy session, whatever that TIP is also happening and it's causing mayhem in their life. It's leading to a life that is not aligned with their values. Right? So we're always linking it back to that. It's not like our quirk. It's not like the thing we're just annoyed by. We're attending to the TIPs because that's how we can help them generalize change in their real life where these TIPs are life interfering. So we're going to pay attention mindfully, expecting non-judgmentally. And as I've already talked about, when we need to, we will directly target TIPs from a contingency management perspective. Right? We'll use all of the things we know as good behaviorists. We'll reinforce as needed. We'll only rarely use aversives as needed. We'll problem solve. We'll model. We'll block. We'll differentially reinforce. Right? We'll role play. We'll do all these different things as contingencies for the TIPs. And what this ends up translating to is we end up talking less about the content that we might have been talking about, and we end up doing more actual change on the process that's underlying the content. Turn the content into process. Turn your content into process. This is how we do it. Our next step after we've done our contingency clarification or our contingency management when it's happening in real time, in DBT, we do assessment, right? We want to assess why the TIP is happening. What is the TIP? What isn't it? How do we think about it, right? We do chains, we use functional analyses. We do all the things you all, I think, as DBT therapists already know how to do. And we're looking at all of the antecedents, all the controlling variables on the consequence side, right? We're looking at internal experiences, we're looking at external. When I do chains in my head, my hypotheses and my questions are organized around that basic acronym. So I'm asking questions about behavioral processes, A for attentional processes, S for somatic processes, I for interpersonal, and C for cognitive. BASIC, basic. I'm really using that as a structure, a scaffold to assess the before, during, and after. So your chain that's really a before, during, and after, it's really kind of three columns, right? Before, during, and after, now is actually a 3x5 grid. So we use a 3x5 grid where you've got your before, during, and after, but really to make it more organized and not just look like scattershot the way chains sometimes get drawn out. I mean, let's face it, sometimes when we write out our chains, they look like spider webs with no structure. They're just kind of all over the place. Use the basic structure, and now you've got a 3x5 grid, and you can more systematically organize and understand dimensionally the various biopsychosocial processes underlying whatever that problem is that's a part of a TIP. Okay, so here we might just say something to someone like, let's talk about this for a minute. I think we actually have a really good opportunity to understand this. You, in this example, you have our time sometimes following through on commitments you make, like showing up on time for therapy or, in your life, sometimes you've told me that you can't always kind of finish jobs that you take on at work and it's causing you all sorts of problems. So that's kind of happening in here with us today. I'm wondering if we can look at that today. We can really try to understand it better. And, remember, this is something we've talked about before. And as soon as that very first appointment, we talked about this is a thing that happens in therapy. So it's actually a good thing it's happening. It's not a bad thing. It's a good thing. It allows us to really try to look at this more carefully to understand it. So we're going to get this buy-in collaboratively, and we're always going to be weaving in validation, right? This is part of the contingency you're managing, is you're going to stop and do assessment and then try to really do that chain style assessment to understand what in the world is going on here. And how does it connect to our case formulation more broadly? So that's our next step, is integrating the TIPs you see into the treatment plan or into the case formulation or both. So you're open, you're collaborative, right? You're talking about this with your patient. You're not like secretly holding on to it or just like only telling team members about it. It's something you're just very radically, genuinely open about. This is normal. I actually do a lot of self-disclosures with my patients about my typical common TIPs as a therapist. Like we're fallible, right? Like we're therapists. It's part of DBT. It's part of what drew me to DBT so many years ago is I really feel like I can be myself authentically. And part of that is like I'm kind of infallible. I mean, I'm kind of infallible. I'm kind of fallible, very fallible, extremely fallible, right? So I can say that. I can say, there's things I do. And I explain and I tell them like I'm a busy professor doing all these other things and da 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 da, and I have a crazy schedule and calendar and da da da. So sometimes I'm running a couple minutes late, and that's a thing that I do. And I sometimes I have a hard time. Blah 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 blah. I will explain it genuinely, and then in the context of doing that, try to help them understand what I'm working on as a therapist to improve, as a way to model what I'm working on with them as a corollary in their treatment plan to improve vis-a-vis TIPs. Now, when we have TIPs as processes, we do have this issue where we need to have language that is shared, right? So this is a very, very important point. We want the language we use as we talk about all of this. We see the patterns, we've done our assessment, we're really putting some words together. It has to be collaborative, and the language needs to be really in the patient's way of saying it. It needs to be culturally conscious how you talk about it. And you want to just ask the patient directly, what would you like to call this type of thing? What do you think we should call it together? I just use the word blah, 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 whatever, insert your own process that's like jargony and kind of nerdy and, like the kind of thing we all would say to each other, but isn't going to land with your average patient necessarily. So I might say, I just called it blah, blah, blah. What do you think we should call that? And I want them to come up with the language, their words. I don't care what the words are per se. That's just form, right? I care about function and process. I don't care about form in this case. So the patient tells you, let's call it, blah, blah, blah. Okay, that's what we're going to call it now. So now we'll be looking for blah, blah, blah. And when blah, blah, blah happens, what are we going to do together? Oh yeah, good point. Okay, well, and now you're problem solving. You're in there and you're kind of figuring out like, is blah 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 different than blee blee blee? Is blah 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 different than blow blow blow? The things we've already been working on? Or is actually blah 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 really just blee blee blee? Like, what is it? What do you think? I don't actually know. Right. I guess on the other hand, I have an idea. I think I might know, but I don't really know. Like, do you know? What do you think? Right? You kind of do the DBT thing, right? And really get in there collaboratively. Using this language to update your treatment plan and case con as needed. And obviously, this is all in the context of DBT framed within our treatment hierarchy, and it's framed within the biopsychosocial model. The biosocial model of DBT gives us so many direct hypotheses. And so our TIP language needs to be aligned with that. We'll talk in a few minutes about other therapies and how they talk about TIPs. And for doing DBT, we're going to use DBT's biosocial model. So stay within the model using that kind of language, but then tweak it, kind of turn it, rotate the language over to the patient and what's friendly for them. It's the same thing as the biosocial model. It's just their words. Okay. So next, now we've got all this kind of happening. At some point in this process, we are going to do the work we do to try to actually get in and make changes to these TIPs in the therapy session. And of course, outside the therapy session too. And we're going to use all the tools we bring to the table as behavior therapists, as cognitive behavioral therapists, as DBT therapists. Right? We're going to bring our change strategies in and blend them with our acceptance and validation strategies. We're going to bring in also irreverence, and we're going to bring in our reciprocal warmth and kind of gentle strategies, being steady with the patient, balancing change with no change, right? All the things we already do in DBT, we're now just going to bring them in to focus in on TIPs. So this looks like problem solving, it looks like solution analyses, it looks like troubleshooting solutions, right? It looks like having many different hypotheses collaboratively. Like I can think of 2 or 3 reasons why this might be going on. What do you think? We did this chain together and it seems like based on the chains we've done before, I might think A, B, and C might be reasons, hypotheses, right? Reasons why this might be going on. Wow, but what do you think? What do you think? Always tying this stuff back to clinically relevant problems outside the therapy. Always, 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 always connect, make that bridge. In these moments, you are a civil engineer building a bridge from the therapy session out into the patient's everyday experience. You have to build that bridge. You have to. Otherwise, what are you doing? You're just making change in the therapy session. Whoop-de-doo. Good for you. You just changed something in the therapy session. Guess what? They got a life to live outside the therapy session, right? So, we got to really explicitly make change generalize out into the real world, starting with connecting it to clinically relevant problems. We're going to do our dialectical strategies of pros and cons and refining our solutions and coming up with new, better solutions. And then as much time we have left, we'll use to kind of further refine the pros and cons of those solutions and so on and so on and so on, right? Okay, and at a certain point, we now have strategies we figured out. Now we're going to start implementing. Again, we're directly going to use skill training in DBT. You all know DBT skills. In non-DBT audiences, I now go in deep on all of the DBT skills, but I get to skip that for you all. Thank you. So here, yeah, exactly. So here we just use any of the skills that we know are likely to be helpful for that patient to disrupt those TIPs. You're going to do all the things you know how to do as a DBT therapist, modeling, role playing, rehearsing, coaching, blah, blah, blah. All of that stuff you already know so well. You're just doing this in real time. One of the things that I don't think we as therapists do enough and can't be said enough, we need to choose the skills the patient is most likely to do. The very best intervention, in my opinion, is always the same one. And it's the one that the patient is most likely to do. It's not the one you want them to do, right? It's the one they're most likely to actually do. That's the best intervention. So we have to kind of figure that out. Like among the different things we could do to change this process, what do we think is most likely to work for you? And then we got to move into context. For context, my visual is always a ladder. So think ladder, where the highest part of the ladder is the hardest context to implement the skill. The lowest rung on the ladder is the easiest. And context is biologically nuanced and situationally nuanced. So we need to understand all of the rungs on the ladder, biologically and situationally, that make change more or less likely to occur. Right? What are the things, right? So these are vulnerability factors on the biological side, right? They're situational vulnerability factors as well. And we want to figure out what's the easiest first step that we can get this to start to change in so we get some momentum behind us. As DBT therapists, we're going to use dialectical strategies to try to get engagement to make changes here. All of the strategies you already know, we're just going to use them, right? Like we would with anything else in DBT. But note that what we're focusing on is these underlying processes using this basic model. We're really focusing on those. And we don't care which skill it is unless as long as it's a skill that they're willing to do. We care a lot about the context they're implementing it in. We want it to work. So our commitment strategies are very pragmatically organized around effectiveness. So our last step here is that the ongoing targeting of TIPs is used after that session. So they come back the next week. You want to bring it back up, right? You want to have ongoing targeting of the same TIP processes so you can work to have change and consolidate and generalize learning, right? So not only are we using those commitment strategies between sessions, but we're also going to, over time across sessions, do a really thoughtful plan to generalize learning from easier to harder contexts. We're going to regularly follow up with consolidation questions. We're going to listen, like really listen carefully when our patients are describing their insights about what they did differently. We might use inquiry as a style of listening where we're really listening with curiosity and going one or two or three levels deep with what in MBCT they call inquiry, right? Where you're sort of listening and then inquiring about the response to go deeper and deeper. You're trying to generate insights, right? And we're also really carefully listening for expectancy violations. When I did this differently, I was surprised. I was surprised. It wasn't so bad. I didn't raise my voice at my mom. Instead, I just kind of used half smile. I thought it was ridiculous, but I did it. And actually, I was surprised. It actually helped. Like she didn't get upset with me like she normally does. It's a really kind of weird experience, but kind of cool, right? Expectancy violation just happened. Listen to that, reinforce that. And over time, you're reinforcing the changes in these TIPs out of the session, but also critically in the session with you. You can't be afraid, right? We DBT therapists, we are anything but afraid. We are a courageous bunch. And so we're going to, say things in a very validating way that are shining a light on those incremental changes that are being made, even if it feels uncomfortable for us. Always linking again changes in TIPs back to a valued life worth living. This is another wrinkle I've added in my career that is not part of original DBT, but I always use it. It's not really a life worth living. It's a valued life worth living. We want our patients to really know what's important to them, it's meaningful to them, and help them get that. That's a valued life. Not just a life to stay alive, but a life that's valued. Okay, so these are our 10 strategies with our patients. Real quickly, when we think about ourselves as therapists, we're going to follow many of those same principles we just walked through. We're going to use our team. We're going to use our own mindfulness skills or practice. We're going to use our capabilities for self-reflection. We're going to use our peers and colleagues, and we're going to listen to our patients over time as we learn our own patterns. We need to understand our biopsychosocial patterns, our contexts that elicit our TIPs. And dyadically, of course, with certain kinds of patients or certain kinds of patient TIPs, we are more likely to engage in certain kinds of therapist TIPs, right? So we got to understand that, be really open to that. I use my basic acronym again here to think about, what are my what are my TIPs behaviorally, attentionally, somatically, interpersonally, cognitively? What am I most likely to do and in what context? And I've just given examples here. These are just examples, right? These are all therapist TIPs. These are common things that happen for us. We want to intervene on them. Our consultation team is really a wonderful, loving place when it goes well for this to be attended to, right? And I think it's worth saying too that there's some ethics behind all of this, right? We as therapists are engaging in ethical behavior when we are self-reflective, assessing our own tendencies and biases, and really working to minimize the adverse impact of our TIPs on our patients. Right? Okay, last couple slides, then we'll do Q&A. So I just want to say here for these next couple slides that DBT is not the only therapy with a model for therapists to pay attention to therapy interfering behaviors or processes. And this is just a few examples. On the left, you have treatment type example, and then the middle column is like what they might think of in that treatment model outside of DBT as a predictable type of a category or class of what we in DBT would call a TIB, or after today, maybe you call it a TIP. But this is like their version of that, right? And you can see on the right column, examples from each of these therapeutic modalities about how in that particular treatment approach, they might talk about or have a model for how to make sense of that therapy interfering problem. So DBT is anything but unique in paying attention as Romia, you said this at the very beginning in the introduction. I think you're exactly right. We just have our way of doing it in DBT, but every therapy has a way of doing this because this is such an ordinary thing. The thing that our patients come to us to get help for gets in the way of them getting the very help they seek. This is a human thing and a therapy thing, not a DBT thing. Busy slide here, but I wanted to just also contrast DBT with three other evidence-based treatments for borderline personality disorder. It's the same structure as the last slide, but it's kind of more detailed, and it's really just around BPD. So if we look at transference-focused therapy or mentalization-based therapy or schema-focused therapy, all three treatments with an evidence base suggesting they may be efficacious approaches, just like DBT is. These may be options if they're available for BPD. And all of them have their own kind of similar type of construct, don't they? They're just different words, and the words are different because the theoretical model is different. And the way that they identify different patterns has kind of different language than maybe we might say superficially in DBT. We don't use the word psychic equivalence as DBT therapists. This is not like a word we would use. It's not part of the biosocial model. We don't use the word mentalizing necessarily, but we have our own words that really reflect those things, don't we? Really, all we need is somebody to make a glossary of all this stuff so we can have a crosswalk. Maybe somebody's done this. I haven't ever seen it, but a real nice crosswalk across all the treatments where we can translate. Just like we do when we're in other countries and we don't speak the language, we kind of have a crosswalk, a way to understand. If somebody's ever done that, please tell me. I'd love to see it. So there on the far right, we have strategies that each of these treatments uses to maintain or to maintain a focus on what we would call TIBs or TIPs. Okay, I'm not going into all the details of this. It's just really the high level takeaway I want you to have is treatments for BPD all have some clearly organized set of strategies to help therapists manage therapy interfering processes, just like DBT. This is my last slide, and this slide here just says, if we take our 10 strategies I've taught you today, born out of DBT, born out of the book that Alex Chapman and I wrote 10 years ago, all you have to do is slightly modify, just slightly modify to be able to do these same strategies outside of DBT. You might see patients only from the perspective of DBT, but some of you, my guess is most of you, if not all of you, also see patients where you're not just using full model DBT. You might be using other strategies. And so this is for you. This is for you, that the only real changes that need to be made outside of DBT to make it more broad are to stay within the therapeutic model that you're in when you're assessing. Stay within the therapeutic model you're in when doing the interventions. Stay within the therapeutic model you're in when engaging in strategies to enhance motivation. That's it. It's the same 10 steps, I think, in any therapy. Okay, and so here we are. I'm going to just land on this page for questions. This is that book that Alex and I wrote. If this is something of interest to read more about this, that is what that book looks like, Managing Therapy Interfering Behavior. And Romia, I am yours for Q&A.
Um, yes, so thank you. This was very, very valuable. I think not only for me, but for all of our very trustful viewers for tonight and all of the people who are going to view this afterwards as well. So one of the things you said, what I noticed was that addressing therapy interfering processes are a part of every therapy that deals with BPD, right? So at the same time, especially working with maybe like younger therapists, I've noticed that it's quite often, dismissed or like overlooked. So what advice would you have for the therapists who have just begun and they see that there is clients, TIPs, but
Yeah.
their own TIPs are interfering them from addressing this.
That's such a good question. I work with students in graduate school who are in their third year of their PhD training. It's their first practicum ever in a hospital. It's their first time they're ever really working with patients outside of a kind of a training wheels style clinic. And what I do with those very brand new therapists, and the same thing with therapists that I'm training in workshops, wherever in the world, is I focus a lot on really deeply understanding yourself and normalizing that we're humans, we are imperfect, and that we need to talk with our supervisors about our own tendencies. The short answer is with my own supervisees, I have conversations with them early on in the year of training. See if this sounds familiar, where we talk about and normalize how therapists are likely to unintentionally get in their own way. We talk about their most likely patterns behaviorally, attentionally, somatically, interpersonally, and cognitively that might unintentionally get in their own way. I share and self-disclose my own patterns that I've been committed to working on over my career that get in my own way, right? In other words, in supervision, we can do the same kinds of things that I just walked you through to do with our clients and patients. And normalizing this, I can't emphasize enough to whoever is listening the importance of normalizing early and often, making this very genuinely, very radically an ordinary part of psychotherapy. That's most of it, right?
Yeah.
And so much can be talked about with those two parts of what I just answered, like normalizing it and then, modeling and then going in and doing assessment with learners.
Mhm. Yeah, so this has been, at least for me, somehow also your answer has been validating that it is normal for everyone to experience this. Um, one other question I have that is a little bit more specific. You said that you are three times gently highlighting the patient's TIPs before addressing the pattern, if there is a pattern. Does that go for all of the behaviors?
No, no. And I was saying, I say that as a kind of a principle to
Mhm.
consider instead of assuming the first time you always should just go in and change. The teaching point there is not that you always wait three times. No, no, that would be a rule and it would be context insensitive. And that is anti-DBT to have context insensitive rules, right?
Mhm.
But the reason from a teaching perspective to focus on that, and I'm glad you noticed it because this is why I make that point, is it allows you to kind of think, oh, I don't have to respond right away and attend to it deeply. I can just notice it and I can come back to it later.
Mhm.
If it's something that I'm not sure that I need to intervene on right away, I don't have to. I'll give it two or three times.
Yeah.
So a learner will come into supervision with me and say, Zach, my new patient, this is what they did. What do I do? And I might say, well, how where is it on the treatment hierarchy and how much do we think it's understood already as part of the treatment plan? Or is this something really new? And if they say, oh, this is something new, this is just a new thing I noticed, and I didn't really know how to make sense of it. Okay. Did ignoring it cause any direct harm to your patient? No. Okay, no evidence that it caused harm to ignore it. Okay, good. Would immediately have attending to it. If you had immediately attended to it right away, is there any reason to think that might have disrupted whatever you were working on in that moment? Yeah, I kind of thought I shouldn't do that because of da 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 da. Okay, okay. And so is it something you could be curious about and look for next time and just kind of listen for and see if it emerges again? Just do that. Just kind of keep listening and looking for it. Okay. Right. So it's a way to just let that therapist who's learning know that they haven't failed, just because they didn't do anything right away.
Mhm.
We're looking for patterns. The operative word with a lot of this is patterns, right? We want to notice patterns. if a particular thing happens one time, it's not a pattern. It's just a random behavior.
Mm,
Most of our TIPs are not, though, right? They're patterns. And so we want to listen and look and highlight. Sometimes when you highlight, you end up not intending to go in and do any deeper work, but you do anyway because of whatever happens, right? The patient responds to it, or
mm,
you guys decide, okay, let's look at it a little more deeply.
mm.
But you don't have to. The notice it up to 3 times is a way of saying, look for patterns. You don't have to just jump in at every single time there's a TIP you notice.
Yeah, yeah, yeah. So we have also a question from the audience. Um, so I will just, are you, so there is a viewing of therapy interfering processes in ordinary cognitive behavioral therapy models. And the question is, are you aware of CBT folks using TIPs in CBT models as explicit as in DBT?
I think what's explicit in DBT, thank you for the question. I do think one of the unique things that DBT brought to the table in therapies is directly explicitly naming this as a class of behavior as therapy interfering. I think, that was that choice Marcia made to do that decades ago. I do think that is unique in naming it directly that way. So those words are unique. Those words are unique. On the other hand, dialectically, I would argue most models of therapy, if not all, have some way of understanding what might be interfering with the therapy and then attending to it. CBT is not, CBT is not a treatment. CBT is a class of treatments. Right? CBT is no more of a treatment than is antidepressant a treatment. Right? There's many antidepressants in the category or class of antidepressants, and there's many CBTs in the class of CBTs, right? So DBT is a CBT. ACT is a CBT. Prolonged exposure is a CBT, right? And so on and so forth. There's dozens and dozens, if not hundreds, of different brand names of CBTs. So if we take a brand approach and we look at the different brands, I mean, that's part of what I was doing here, right? ACT is a type of CBT. PE is a right. Some of these are types of FAP is a type of CBT. They're all different, right? They're different, but they're in a same category of big C, cognitively focused, or big B, behaviorally focused, very change focused versus very acceptance focused or mindfulness focused, so on and so forth. Um, I think the short answer is yes, it's unique to call it that, but no, I don't think it's unique across CBTs. I do think some CBTs are really, I think some are very narrow. Like for example, in PE, the primary way you explain and understand and work with what we would call a TIP or B in DBT is to lean right away right back to avoidance. And I mean, it's kind of like that's the move you make in PE by and large when there's some sort of non-compliance or some sort of moving outside of the protocol behavior that the patient does or the therapist does. The move that's almost always made is education around avoidance and then moving back into blocking avoidance and getting back into doing exposures, right? Or in the case of the therapist, the supervisor helps the therapist get back to doing the exposures, right? Not avoiding them. So in PE as a type of CBT, I think it's fairly narrow how they conceptualize TIBs broadly. Um, we could do the same exercise though if we wanted to go through each of the many different types of therapies in the family of CBTs. They all have slightly different ways of attending to this. Again, I think DBT is unique in calling them therapy interfering behaviors, which opens up, I think, a lot more space to then have subclasses. And I think that's where something like that basic model that's scientifically updated to today's science, no, it's not in the 1991 book, but it is reflective of much more modern clinical science. I think
Mm.
DBT allows that frame to kind of bring in and evolve with new language, unlike some of the other CBT models that are, I think, a little bit more constrained.
Mhm. There is another comment. Thank you for your talk. Can you recommend an article that conceptualizes DBT as a process-based therapy?
The articles that are written, mostly you'll find them if you go into Google Scholar or some other search engine and you look up process-based therapy, you'll find articles written about process-based therapy, not about DBT, but about process-based therapy and what that is as a sort of, a new term for a way that new as of 2018 or so, a new term that Steve Hayes and Stefan Hoffman and others have been really writing actively about, where they conceptualize process-based therapy and therapy approaches and kind of lay out principles. And you'll see when you look through some of those articles that DBT is one of many different therapies that are highlighted as being very process-based.
Mhm. Yeah, and I think also in the Red Bible, Marsha has written quite good about process-based therapy
Well,
aspects.
100%. The term process-based therapy didn't exist when Marcia wrote the book, or it just wasn't around. But process-based approaches have been done for many, many, many years before the term has started to now take traction.
Yeah.
What's different now and what's new, besides the term process-based therapy, what I think is really new and different compared to years ago is that there's a lot more clinical science that's occurred over decades that gives us an understanding of mechanisms of change, of processes of change, um, of biopsychosocial underlying kinds of processes. We have a science about all of that that we just didn't have in 1991. It just wasn't there,
Of
right?
course.
And that was now a long time ago. And thankfully, we've had a lot of science happen in the intervening decades. And so the science has given a way for therapists to understand dimensionally what the classes of processes are that they're targeting, what the words might be, and what the scientific rooting and anchoring is for that. And it allows therapists to then think about very idiographic case formulation driven treatment approaches that can integrate either in a modular way or in a sort of very, very truly idiographic way, can integrate techniques from different therapy approaches that are known transdiagnostically to change the processes that are relevant for that patient. And so how we can think about DBT similarly to how we might think about ACT or the UP or MBCT or BA or PE or other types of evidence-based therapies. They all have processes of change that they, from the get-go, a priori, say they're targeting.
Mm.
Let's think in DBT. If you had to say, what's the most central organizing biopsychosocial process at the core of the biosocial model that we're targeting? What is it?
Oh, I didn't I didn't know I have to answer it.
You don't have to answer. I can answer it, but what do you think? I mean, you can if you want to.
Uh,
I think we would all say the same thing. We would say it's
yeah,
emotion
emo
regulation.
yeah, emotion regulation and
Yeah,
invalidating
and
environment.
what Marcia said for decades and what people have written about for decades is that BPD, from a biosocial model perspective, BPD is a all of the sort of symptoms, all of the sort of domains and symptoms of what we call BPD. They are either caused by problems with motion regulation, or they are the consequence of motion regulation. So in other words, they're either cause or consequence of emotion regulation. So I would say DBT is a process-based CBT approach that emphasizes emotion regulatory processes of change, which of course they themselves are many, right? Because that's its own kind of construct to double click on and look more closely into. If we did the same exercise, let's say with the unified protocol, we would have the unified protocol as a process-based therapy that is constrained to certain processes. Those processes would be emotional reactivity and emotional avoidance. That's you read about the UP, that's what they say. This is a treatment for that, right? We do the same exercise for ACT, and we come up with a similar thing where we'd say, well, ACT has very clear processes that it says it targets. And they're organized around the hexaflex model of ACT, right? They're organized around psychological inflexibility as the core transdiagnostic process to change. And then there's these sort of, hexaflex kinds of lines to all six of the different sub-processes that link up to psychological inflexibility. What's the point? The point here is that each of these evidence-based therapies are process-based, but they target certain processes, not any and all processes that
Mm,
exist. Yeah.
mm,
So PBT is a way to sort of say, okay, there's no such one therapy as PBT. It's really just a way to understand all therapies. What processes do they target? What's the minimal credible scientific basis for that? And how might we tailor treatment to each individual using that approach? This is all stuff
mm.
it's not, I know, not the focus of this training. I'm happy to do that another time. But the person asking the question
Well,
can
there
read
was
about
a
it.
question.
Yeah, yeah. It's a great question.
Mm. So we have several thank yous from Anna Lindstrom and Eva Bitte as well, who are thanking you for your webinar. Just before you finish, a quick question from my side. Is there anything you feel that you have missed or wanted to note before we say goodbye for tonight?
I think a thing that we didn't talk about in here that is useful is to think cross-culturally and to think more, wherever folks live that are listening to this webinar, to think about how they might understand culturally nuanced TIPs and how they might kind of bring that awareness of cultural differences or maybe not differences, depending on therapist's own culture, but just to really kind of be thinking about what's normative, what's not, what works, what doesn't from that cultural or cross-cultural lens. I didn't talk about that much, but I think that's a really important piece to understanding all of this stuff.
Yeah, being sensitive to the cultural differences.
Mhm.
Okay, so thank you very, very much. Thank
My
you
pleasure.
to all our listeners and watchers for tonight as well. Just a reminder that you can watch this webinar and the previous webinars on our webpage, edbt.eu, or here on YouTube. Zach, I'm very grateful for what you've done for tonight, and we say goodbye to everyone who is listening and watching for.
My pleasure. Thank